growing weary of running from room to room, practicing one-tooth insurance-driven dentistry? Then stay tuned for the latest episode of The Lionhearted, where Dr. Stephen Rasner will hand you the blueprint for what many call the gold standard of general practice dentistry.
Hi everyone, Dr. Steve Rasner here. You're tuned in to the Lionhearted Dentist podcast. So here we go. It's a snowy day here in Philadelphia. So unexpectedly, I was shut down at work and I decided to do a podcast. First, let me say hi to a lot of my friends from around the globe. Been getting an awful good amount of attention in France these days. So thank you to my French colleagues in India and Australia. And hey man, you've heard me say it before. I think it's so cool. It really is. Not so much love in South America. You guys don't seem to be interested in what I have to offer, but I'm going to still be here doing this. So when you're ready, I'll be here. So listen, here's how this week's going to go. I was preparing my first live lecture of 2021. That's right, in the United States, in Florida, I'm maybe doing a live lecture. In fact, I spent most of the morning on it. I'm not sure now that it's actually going to happen. But here's the point. I was preparing to make this particular lecture a combination of clinical and how to maximize your potential gems. And those of you that don't know my background, I spent my first 10 years as a speaker speaking on how to kill it, how to put it all together. And I loved doing it. I really did. And for the second 12 years of my speaking career, I have focused mostly on clinical aspects of maximizing your potential. So the oral sedation you hear me refer to, atraumatic extractions, site development, implant dentistry. And I took 2 of those and made live courses in my office. But I really like talking about both. But today I'm going to take a little side turn on you, and just stay with me, and this is why. I want to give you 3 clinical easy strategies that you can implement even from a podcast. That's the hard part, in my opinion, teaching clinical in a podcast. First of all, you're only going to do it for 30 or 40 minutes or less. And it requires, obviously, physical props to show you. And so I can't do it from my home, etc., etc. If that's something you would be interested in, it would motivate me enough if I knew that to simply do some more podcast from my office to show you. But I have 3 strategies that you could even listen to if you're driving somewhere right now or you're on a treadmill. You don't really even have to write it down. You can go back and look later if you wanted to podcast and get the details. I thought about these 3 strategies I wanted to give you. And I want to say to you, at every motivational or management lecture I gave those first 10 years, I always said, clinical excellence will take you further than any management tip that I or anyone else could ever give you. So, you could do everything I say in these videos. Have the tremendous front desk team, and it's all important. Have a great new patient experience, have follow-up care, a recall system, leadership and motivational style that keeps your team together for years and years. But if you're clinically below average and haven't even tried to address that, how would you know that? I think if you pay really attention to what goes on in your office each week, it'll give you an honest answer. If you're making a number of incorrect diagnoses, for example, if you treatment plan, I think everybody in the world has treatment planned a root canal and a crown on a tooth that ended up being extracted within the first 3 to 5 years. Well, if that happens frequently, maybe you need to reassess the teeth that you're taking this leap with. If you have crowns that just seem to always have recurrent caries within a year or two at a recall check, I think that is an indication that you need to pay way more attention to this aspect of your dentistry. If your implant failure rate is way above the norm, I think it's a matter of being honest. And to be quite frank with you, there's times in my own career where I am just brutal to myself that I haven't maintained or reached the criteria that I expect of myself at this point in my career. So I think it's important that you have everything else and your work is reliable. So here are the three that I want to share with you. And they're pretty easy. And I think they have an instant impact to you. In other words, it's not just that you're going to become better clinically with what I'm about to share with you. It's that it has an impact on your whole practice, as you'll see. So the first one is I put the really in quotes, painless injection. What is your technique? Here's what it should be. Okay. For all injections. Now, keep in mind something. I have an extraordinary percentage of my patients that are orally sedated with a cocktail you hear me talk about in many, many podcasts. Even with them, we're using this protocol I'm about to give with you. And even if for the patients that are not sedated, let's just be honest with each other. Getting numb in the dental office is not something anybody looks forward to. I know you have a number of patients, you can do anything to them. It's not who I'm talking about. I'm talking about the people that here's the thing. You may have a number of patients that tolerate the injection. What if when you gave it, the reaction was, wow, honestly, doctor, I know it was an injection, but that was the best approach I've ever had. You know what that leads to? People talk about you. The kind of talk that you want them to say. And the technique is very, very easy. And here's what it is. For all your injections, infiltrations, mandibular blocks, you're going to use 2 needles, a 30 gauge and a 27 gauge. In the 30 gauge, you're going to use Citinest, plain, 4%. Okay? Why? Because it has a neutral pH, and there's not a doubt about it that when you inject with Citinest, it doesn't have the same bite or sting as lidocaine or articaine or whatever you're using. So you got to say to yourself right now in this podcast, do you even care that much? Maybe you don't care. Maybe you don't want to go to the trouble of 2 different syringes out. It becomes protocol in a matter of a couple days of doing it, so it's nothing. One set up with 30 gauge, one set up with 27 gauge. And what you're going to do is you're going to start the process, so we're backing up a little bit, with a topical anesthetic that actually is different. Now, for those of you in other countries, you obviously can't get what I'm going to give my American and Canadian partners. So I'm going to tell you what it is. It's 100 milligrams of lidocaine, 100 milligrams of prilocaine, and 40 milligrams of tetracaine. So just take that to your pharmacy, see if you can put it together in some kind of gel that doesn't taste awful, and that's what you want. In the United States, you guys can either write me, Dr. Rasner, DrRasner at AOL, and I can resend you the number. I use a pharmacist company out in, I think it's Indiana, and the number is 615-237-3234. And if I didn't feel it made a difference, then I would tell you to use Ceticaine or whatever you're using from your dental supplier. It makes a difference. I've been using it for 25 years. Okay, so you're going to start with a topical that matters, that has an impact that really does anesthetize the mucosa. Then you're going to go in, if it's an infiltration, with a 30 gauge 4% sit nest. And what you're doing is you're just giving a few drops wherever you intend to give the anesthetic of your choice, which in my case is always Septicaine, which is also Articaine. Okay? And any infiltration, that's what I use. I've talked to many, many experts that are smarter than myself that have explained that it has a better capacity, that being Articaine, to penetrate the cortical plate. I don't know what it is, but I know it works better and more profound in 40 seconds than anything else I use. So that's that story. What about a mandibular block? With a mandibular block, again, we're going in with a 30 gauge with sit nest, and we're going in about half the distance to our desired goal. And then I wait, and then I go the rest of the distance. This is with a 30 gauge, just short of bone. Now remember, the only reason I'm doing this is so that when I turn around to get the 27 gauge with lidocaine for a mandibular block, they don't feel the lidocaine go in. So the only purpose of the first shot, and mandibular blocks are not comfortable. I don't care who's giving it. They're just not comfortable. And if you give it the way I just said, it's minimal and dramatic to the patient. Absolutely dramatic. Now, you notice I didn't talk about palatal. It's a whole different story. And I'll save that for another day. But, for the most part, certainly patients on sedation can handle the palatal shots, of course, of which I'm only using lidocaine or articaine. So, I'm just going to review this for a second. I'm telling you, to me, if I was a young dentist opening up somewhere, anywhere, I would take the time to try what I just told you. 2 syringes for every shot you give. First shot is with sit nest because of a neutral pH. The second one is your anesthetic of choice. And see for yourself. I mean, it is a practice builder over a long period of time. And by the way, it's a compassionate and nice way to be too. So nothing wrong with that. Those of you that need the detail that aren't in front of a screen right now and you want to just write to me, I'll send you out that protocol, or Beth will send it out to you. Okay, the second thing I want to review is those of us, and it's all of us, that are fabricating or treatment planning a conventional denture for a terminal dentition. So this patient that we're speaking about cannot afford implants or can't have implants for whatever reason. So I want to give you my approach. Not suggesting this is profound or groundbreaking. It's what I've done for years. And for 3 reasons, which you're about to see, it makes my life way more easy and manageable, which is my goal for you, which is why I'm on here. Okay. So here's the protocol. When I have a terminal dentition and we're going to a denture, I try to save 4 teeth, 2 on each side, temporarily, out of the aesthetic zone. If I can't, and I can only save 2, when I say save, I mean save for like 3 months or 2 months, the time of the treatment that we're in for. So if it's just an upper denture, if it's an upper maxillary and a mandibular denture, I will take 2 teeth. They could have 70% bone loss. They could have 1.5 to 2 mobility out of 3. They could have a giant carious lesion or a periapical lesion that is asymptomatic. In other words, it's not hurting them right now. And I will save 2 to 4 teeth. 4 if I can get it, and if not, 2. And this is what I'll do. I'll fabricate a provisional partial denture with just acrylic with wrought wire clasp. Okay? Hear me out on this. I'm going to tell you why it makes your life 10 times better. And so what this does for me is as follows. So all that requires, by the way, is an alginate basic impression and a reasonably good bite record. That's it. One visit, send to the lab, and we even have special lab slips just for this type of prostheses. Remember, the lab's going to come back and X out on the model every tooth that we tell them to, with the exception of 2 to 4. They will turn an acrylic partial with those teeth in place. And here's what it does for you. Number one, it fast tracks the patient into a situation that's usually much superior in every way to what they've had when they walked into your office. So you're not waiting. I mean, if you're a clinic, this may not apply to you, but I don't think many clinics actually listen to me. If you're a private practice dentist, think what this is doing. This patient came into you usually knowing they have a terminal dentition, right? And they look dreadful usually. They're missing a tooth or two in the aesthetic zone, or the teeth are chipped, black, malformed, extruded. You know what it looks like. And you're able to take them in a matter of 1 week. Really, you could do it in 3 days. Have them back in if you have the time to get them back in 3 days. For me, it's usually, 2 weeks or a week, depending on the situation. I have them back. They're sedated. We take out all the teeth that we needed to take out. I graft where I needed to graft. And they leave with a temporary partial denture. Well, you may say, well, not just take out all the teeth. Isn't that much more expedient? Taking a patient from a dentition to nothing is a real practice management problem for most patients. And when you leave in even 2, 1 on each side, if you can, beat up teeth, it is so much easier for you to manage that patient through the rest of the treatment protocol required for a conventional denture. Okay, so you're replacing all the teeth in the aesthetic zone. So let me tell you what else it does for you. So number one, it motivates the patient because you took them from this hapless dentition to not looking too bad. Remember, these patients aren't patients with a great dentition. They are very appreciative that they look so much different in such a short period of time. So it takes the gun off your head, if you will, to get done the case in 3.5 weeks also. It allows you, here's what I do. I allow them to heal for 6 weeks, really often 12 weeks, before I take the final impression. And all I have to worry about are the 2 to 4 teeth that are remaining to heal. Well, that's a lot better than a whole arch that has to heal. By the way, a key to this is the patients come in every 3 weeks, and my dental assistants do 90% of the work. We reline these provisional partial dentures with tissue conditioner, and I use one called Sultan, Sultan. Sultan is actually the company. I'll get it to Beth so you can put it up here, what we're actually using. I can't think of it as I'm talking to you right now. There's multiple tissue conditioners that you can reline these partial dentures with. So number one, you got a happy patient. In a matter of a week, they look different. And they have a lot of pathology gone out of their mouth. And they can even function better, even though they only have 2 to 4 teeth left. Compare that with somebody that you took all their teeth out. And by the way, once in a blue moon, there are no teeth. There are no teeth that I can keep. So I have to go to an immediate denture. You know what it's like. They come in every couple days and they're gagging and they can't handle the full palatal coverage. So the other thing it allows you to do is when you get closer to final impressions in that part of it, you can try in all the teeth in the aesthetic zone because you have removed teeth in the aesthetic zone. On the final case, there's no guesswork. You can get the exact mold you want. You can create some individuality and character in the setups that you can't do if their actual teeth are there and you planned on an immediate replacement. It is a win-win-win. So I don't charge a lot for that, and you can write to me and ask me what the fee is. But the summary that I'm telling you is when you're making a denture, a full conventional denture, by the way, I do exactly the same protocol if it's an implant retained prosthesis. So I only keep the teeth in the posterior behind where the bar would be. So I find it incredibly patient friendly to go down that route. And I've never, not literally one time I can recall, had a patient that declined because of the extra costs of the provisional. And again, you can write to me and I can give you a recommended fee for that. It's not a money maker. It's a patient management appliance is what it is. You don't have to worry about speeding it up real quick. You can wait for the ridge to heal itself before you take final impressions. It's tremendous. And then the last one I want to give you concerns the patient that is not a terminal dentition. They don't have to lose all their teeth, but they can't afford the work that they really require. And I want to tell you an aside that I met a doctor, it must be 20 years ago now. No, it's more than that. And by teaching him some of the principles I'm sharing with you right now, I took his practice from 700,000 to 2.6 million. And I never stepped foot in his practice. And this doctor generously shared with me abundant information about implant clinical dentistry that I got to learn. He would come to me, he would fly to my office, teach me things, and I would take him out to dinner and share practice building things. The biggest thing I gave him was what I call the putting out the fires treatment plan. Putting out the fires treatment plan. So that's the patient that just can't afford implants, full coverage crowns, and really doesn't need all of his teeth pulled. But maybe they need their teeth pulled, including in the aesthetic zone. So that's who it's for. What does it include? And I have written information on this. It doesn't require anything with a huge commitment for future treatment yet, because we don't know what that treatment's going to be. So it doesn't include implants. It doesn't include full coverage crowns. It would include endodontics on a key tooth you don't want to lose. It would include, obviously, core buildups on those teeth, probably other core buildups on teeth that really require full coverage, quadrant scaling, root planing. You see, you don't really want to commit this patient to a full treatment plan. And I'll say this in a proactive way, because I don't know that I can trust that they're really on board yet. And I don't want them. And by the way, it's not just that I don't want them. They really can't afford the commitment of a $10,000 or $15,000 treatment plan that patient would want. And so instead of getting nothing, or instead of you just pulling or extracting one tooth and see you later, you get the patient on board. So it's really important to make this distinction here. I'm not advocating in any way that you become a clinic and you just put out the fire that made them come to your office. As I was a young clinician, there was many who advocated that that's in fact what you do. When a patient comes in and has a toothache, that you address just the toothache and have them back. And once they're back, you can provide full treatment plan, which never works because they don't come back. Most of them, trust me on it, won't come back. I don't know how it's changed over the years, but it has. And I think it's because your practice becomes a practice of what you influence it to be. If you influence it to be to put a fire out practice, then you'll turn into an emergency clinic. And I don't think that's very fulfilling for most of the doctors that I know. So that's not what I'm advocating. I'm advocating a treatment plan that, yes, has some compromises from an ideal treatment plan. But that's not to be confused with one-tooth dentistry. That's not what we're doing. We're eliminating hopeless teeth. We are keeping all teeth that have favorable prognoses. And by the way, the prostheses that we use for this particular patient is an acrylic partial with cast clasp. So it's not wrought wire clasp that don't fit so well, but they're cast clasp. And of course, in a lot of these patients, we also have a temporary provisional partial to get them to the acrylic partial. But it would not include a bar attached to implants. It usually doesn't include any crowns and things like that. And and it's a good thing, really, even ethically, for you to evaluate this patient and maybe had case type 2 or case type 3 perio. Are they really coming in? Did they really buy in to coming in at 3 and 4 month intervals, as you indicated they should at your consultations? Are they on board? And look, the patient's comfortable and they stayed in this state for years, so be it. Certainly that's better than them getting into a full denture because they couldn't afford root canals or periodontal therapy or beautiful cosmetic work. At least in my opinion, that's a much favorable option to be in a holding pattern. So I call this, again, a putting out the fires treatment plan, because that's what you're doing. You're getting rid of hopeless teeth that hurt, but you're not including ultra sophisticated and hence more expensive dentistry. Another way of looking at it, it's not my way or the highway. And really enlarges that nucleus that you hear me talk about all the time that you need in your practice. People that, do I really have science on how many of these people come back and say, okay, doc, now I'm ready for crown and bridge. You saved these abutment teeth years ago. Here's what I know. They're not a dentulist. I gave them an option to me that was satisfactory compared to more aggressive removal of teeth or putting them in a situation that they couldn't afford the care. And I don't want that either, neither should you. Have somebody make a leap of faith and accept something that they know is going to really trouble their normal budget. And look, I know I'm not their accountant. You can make that argument that it's not my job to worry about that. I think from doing this for a long period of time, and I think you as well, we get a sense for a patient, what's comfortable that they can fit in their life. And that's really what it's all about. So the 3 things I gave you today, I don't normally talk that much clinical, was an injection technique that'll have people talking to their friends about you, about how I approach even the terminal dentition patient that's going to end up with a denture, a new way to look at that buys you peace of mind and makes it easier to manage that patient. And then lastly, a treatment plan for patients that have no other alternative, that are stuck. They just can't commit. And by the way, these treatment plans can be $5,000-$6,000 as well. Multiple tooth extractions, scaling and root planing, provisional partials. It could even be more. Anyway, I hope this helped you, and give me feedback, and thanks for tuning in as every week to the Lionhearted. See you next week.